we're going to continue with our program now with our next panel, The Lived Experience, Communities of Color, Disability, and the Physical and Mental Health Impact of COVID-19. And to moderate this panel, we have Marco Damiani. Marco, the floor is yours. Thank you.
Very much, Jonathan. And thanks to everybody again for joining us today. The panel I have today is terrific. I'm very honored to moderate the discussion with them. Using the lens of lived experience, we're going to discuss COVID-19's impact on the mental and physical health of people living at the intersection of disability and race, and the various systemic shortcomings, failures, and lessons learned as we continue responding to this public health crisis. Our panel members have unique experiences and perspectives: primary care provider, a behavioral health policy practice and advocacy expert, criminal justice reform, and a frontline manager in a residence for adults with IDD. We're going to capitalize on this terrific diversity of experience. So I'd ask our panelists to please put your cameras on so we can see you and hear you. Great, here we are. Nice to see you all. I'm going to introduce our panelists. We're going to do around the screen here, and then we're going to dive in with our first question. So I'm going to introduce Jennifer Natera, Residential Services Manager at AHRC New York City. Welcome, Jennifer. Dr. Cheryl White-Scott, Senior Medical Advisor at AHRC and a board member of the Human Services Research Institute. Dr. Virginia Barber Rioja, the Co-Chief of Mental Health, Correctional Health Services, Rikers Island, New York City Health and Hospitals, and Dr. Octavio Martinez, Jr., the Executive Director of the Hogg Foundation for Mental Health, and a member of the Biden-Harris COVID-19 Equity Task Force. So welcome, everyone. So I got a couple of questions, and I'm going to ask my first question, and we're going to go in order with Jennifer going first. So here's the question. Please comment on your observed or lived experience of the on-the-ground impact on people with disabilities as we continue to live through the COVID-19 pandemic. And if you can tell a brief story or two, that would add great value to the discussion. So Jennifer, let's start with you. You're muted, Jennifer.
Thank you. As most people throughout the world, from March 2020 on, we all were met with the fear and uncertainty during a pandemic. And throughout AHRC and other companies alike, we were faced with those challenges along with supporting those who live with ID, who are on the spectrum and other comorbidities. And we were raised to the feet of those challenges with positive cases early on. Routines were interrupted, and routines are often important to those who live on the spectrum. It is conducive to their well-being and overall livelihood. And quickly thereafter, things were shut down, such as programs in schools. We were met with the challenges of very little or to no staff. I myself, along with two other staff, were tasked at being at Armstrong, the group home I managed, for about 28 hours straight because people were afraid to report to work because they were already infected or the increasing rate of exposure at the time. And this was early pandemic where ventilators were of question. The hospitals were completely for COVID, and we had to enter these hospitals despite trepidation. We had to fiercely advocate for those who are nonverbal or have other comorbidities where they need that assistance. And often this was hard because if one person's at the home and another person becomes sick, now that's another man down. And we also had to be able to think proactively and get certain members maybe back to their home in order to avoid certain issues in the household, also increase social separation. And last but not least, we had a death in our household. This was an assistant manager who very much so was a beacon at our house. And we had all this going on, not a lot of staff, individuals to support a death, and there was no contingency plan, there was no action plan. Unfortunately, Armstrong, including myself, was tasked with creating that plan.
Thank you, Jennifer. It's quite an experience in the early months of the pandemic, and we appreciate your leadership and your transparency in talking about that experience. It's very important to be able to do that. So, Dr. White-Scott, let's hear from you. Thank you.
Good morning. Thank you, Marco. My name is Dr. Cheryl White-Scott. I'm an African-American female with peppered gray hair, glasses, wearing a black dress with a multicolored scarf sitting in front of a mantle. Most importantly, I'm an internal medicine physician who has provided medical care to individuals with developmental disabilities over the last 34 years. And also, as my colleague Jennifer, worked in many different settings. I provided medical services. I've worked on educational and awareness for health practitioners, worked on policy and planning on the local, state, national, and international level, with a focus on holistic healthcare for people with disabilities. I say all of this to let you know all of my training and experience and knowledge do not prepare me for the onslaught of COVID-19, especially in providing care to an already underserved and marginalized population. So let me just give you a snapshot of what I had to deal with from my personal perspective. As I reviewed the challenges, I realized that unfortunately for many, the true impact may never be known. As I sent people to the hospital with disabilities, as was mentioned even in our prior panel, many were sent back to congregational care settings or home because although they were sick with COVID-19, they were, quote, not sick enough. Who made that decision? How was it made? What was it based on? Was it true medical knowledge, or was it based on implicit bias by health professionals? I was there to advocate along with nurses, family members, and support staff to work with people who had to be admitted, to advocate for treatments that were indicated. But I noticed big differences. Which ER did you get sent to? Which patients were given treatments, such as remdesivir? What pharmacies had vitamin C and Tylenol left? Whether or not you had a pulse oximeter to monitor your oxygen. We had to fight for PPEs for direct support professionals, many of whom are also people of color and women. They continued to work at much personal risk, and we had to fight for their rights. We had to fight for testing once available and worked with limited resources. These were the real life experiences that impacted people of color across the city and compounded impact for people with disabilities, and clearly articulated by our keynote speaker, Daniel Dawes, a lot of the underlying implications of the political determinants and social determinants of health determined the survival for people that I cared for. I'm a clinician, not a researcher, but I think it's important to know we need data on how COVID has impacted communities of color and the limited data we have on COVID on people with developmental disabilities. For example, Scott Landis in Syracuse has gathered some of the data and evaluated on the impact in New York on people with intellectual and developmental disabilities in congregate care settings. However, the impact on people of color with developmental disabilities remains virtually invisible in data and in real life. So let me just give you a quick example and a story. ST gave me permission to share her story. And we started out long ago as patient and doctor, and now we're good friends. She has her own medical team, but she still relies on me for support. She's an African-American female, only a few years older than I am. She has her hair in braids and also wears glasses. She's a person with cerebral palsy and used to be able to ambulate with crutches and now uses a power wheelchair for mobility. She would tell you first and foremost that she is a survivor. She wants her own apartment, but currently lives in a residence with 2 other women and has her own bedroom. She has high blood pressure and asthma, and she takes only a water pill and is very health conscious. The pandemic hit her hard in March. There was no outside activity. Her family was unable to visit, and she was limited to her phone. In April, she began coughing And she was also very tired and sleeping most of the day. Her asthma pump wasn't helpful. And this was Monday. By Thursday, she was almost passed out and she went to the ER, even on her own accord. This hospital is predominantly in a white upper middle class neighborhood in Westchester. It was chaotic in the ER. Nobody knew what to do. Remember, when she arrived, nobody could go in with her. She's used to advocating for herself, but wasn't prepared for this. She laid on a stretcher in the hallway in the ER for hours. Her breathing got more labored, coughing got worse. She asked over and over for help. She had her cell phone, but no charger. She called with her last few dots and said, "Dr. Whitescott, I can't breathe and no one will help me. I need help and they aren't hearing me." Now, as a Black person in America, hearing the words, "I can't breathe," sends chills down my spine. But let me be clear that it is my belief that if this had been a white male executive that had come in and walked to the stretcher and said, "I can't breathe," even in the chaotic COVID-19 ER, he would have been heard. ST was diagnosed positive for COVID-19 and treated. There's much more to her experience, including the need to quarantine in a nursing home prior to returning home, despite family members willing to support her. And again, I believe they were not heard and respected because they were African-American women. But in the interest of time, I'm going to stop there. But I will say that we have much work to do for systemic change of health disparities for people of color with disabilities. The power and resources needed to implement the changes are there. So let's just do it and use what we learned from COVID-19. Thank you, and I turn it over to my other panelists.
Thank you, Cheryl. You occupy a unique space for us, and your ability to be on the ground providing primary care, but to have really a national perspective on disability advocacy and rights is incredibly powerful. We appreciate your contributions so far. Let's go to Dr. Barber Rioja, Virginia.
Good morning, everyone. So my name is Virginia Barber Rioja. My pronouns are she, her. I am a light-skinned Spaniard with black long hair, wearing glasses and a black shirt. And I want to start by thanking Marco Damiani for inviting me to participate in this symposium, and really for thinking about the incarcerated population as an important part of this conversation. I am the co-chief of mental health with Correctional Health Services, New York City Health and Hospitals, which oversees healthcare in the New York City jail system. And I'm really thrilled to be able to share with you my perspective on how COVID-19 has amplified the already existing tremendous inequalities at the intersection of disability, race, and ethnicity in incarcerated individuals. I'm going to start by providing some statistics that I know you are all familiar with, but it's always important to sort of remind ourselves about these racial inequalities in the criminal justice system. It is not secret to anyone that individual and systemic racial bias and discrimination have led to an overrepresentation of people of color in the criminal justice system, specifically Black, Indigenous, and Hispanic individuals. In the US prison system, Black and Hispanic comprise more than half, about 57% of those incarcerated, in spite of being about 29% of the US population. And this situation is no different in New York City, where according to the Department of Corrections, as of 2019, 53.3% of incarcerated individuals were Black and 33% were Hispanic. And so, the vast majority of our patients and people who are incarcerated in the New York City jail system are people of color. There is also, although lots less data on this, but an overrepresentation of individuals for the LGBTQ community. But in addition to all of that, there is an overrepresentation of disability in the criminal justice system. When we talk about behavioral health needs, I mean, I think it's known to everyone that there are more people with mental illness incarcerated in jails across the country than in any psychiatric institutions across the country. And it is estimated, although the data varies depending on the studies, but it is estimated that about 16% of individuals who are in jails meet criteria for serious mental illness. And we're talking here about diagnoses like schizophrenia and other psychotic disorders, bipolar and depressive disorders. And this is compared to about 3 to 5% in the general population. So you can see the the significant increase. But also incarcerated populations have higher rates of neurodevelopmental disorders. There is unfortunately very little research on this, but in my experience, we see it in our daily work in the jails. Also increased numbers of people with neurocognitive disorders, especially as the prison population is aging. Consider that according to the US Department of Justice, rates of admission to prisons for people 15 and older increased by 300% between 1993 and 2013. Also increased rates of traumatic brain injury and substance use disorders. And if all of this was not enough, we also have incredibly high rates of trauma-related symptoms and post-traumatic stress disorder, which can cause significant impairment in functioning in this population. So with all of that in the background, I want to now focus on how COVID-19, from my experience and from our experience in the New York City jail system, has really exacerbated all of these disparities. People who are incarcerated in jails face a disproportionate risk of COVID-19 due to several factors, including difficulty physical distancing, primarily, also rapid turnover, also the fact that civilians, right, our own health staff, Department of Corrections, were coming in and out of the jail and potentially getting COVID-19 and bringing it inside of the jail system. And so this resulted in significantly higher rates of infection in jails across the country relative to the general population. And in addition to the incarcerated individuals being more likely to get COVID, there are several factors that place them at increased risk for poor outcomes. Some of them that I have already mentioned. So the fact that they are an aging population with mental illness, with high rates of chronic medical conditions, and with substance use disorders. But I really want to focus more on the mental health impact of COVID-19 on the incarcerated population, a group already impacted by racial and health inequalities, and as previously mentioned, high rates of disability. First of all, we know that the Black and Hispanic communities were disproportionately impacted by COVID in general. So this means that our patients were getting news about their family members being sick or dying on a regular basis and without being able to be there for them for support. In addition, visitation, which is one of the main protective factors for a number of negative outcomes in jails, where visitation was suspended because of COVID-19. And so in a way, it was an isolation within an isolation. Furthermore, courts also closed, which significantly delayed the resolution of legal cases. And as a reminder, people incarcerated in jails, the vast majority of them have not been convicted. So they are technically innocent. And so when facing delays in their case resolution, they were placed in this legal limbo that caused incredibly high levels of stress. And then, of course, patients were afraid of contracting COVID. They were aware of the high rates of infection in the jail. They were witnessing other residents getting sick. They were witnessing our healthcare staff getting sick. And I want to very quickly take this opportunity to just voice my admiration for all of the essential healthcare workers who worked in the jails throughout the pandemic. What the main consequence, I mean, I agree that I don't think we know right now the actual impact, psychological impact of COVID-19 in the incarcerated population and in the general population. But I can tell you that some of the things that we have seen are, number one, a significant increase in self-harming behaviors. I mean, as a reminder, jails are already considered environmental risk factors for suicide. In jails around the country, suicide is the leading cause of death. Suicides in jails are 3 times higher than suicides in general population. But also important to say that not everyone who self-injures does that with suicidal intent. That is, with the intention to die. That self-injury is also considered a manifestation or a symptom of psychological distress, and is therefore not surprising that the rates of self-harm increased so significantly among the incarcerated population throughout the COVID-19 pandemic. I also want to mention something that I think it's understudied and under-mentioned or talked about, which is that violent behavior and agitation can also be manifestations of psychological distress, and that we need to start treating violence as a health issue and not as a crime. In addition, the number of incarcerated individuals who require mental health attention also increased. So we have more people in the jails right now receiving mental health treatment than we had before. And finally, most people who are incarcerated in the New York City jails and in jails across the country end up going back to our communities, which is something that people typically don't think about, right? You think that they are there, they are in the jail and that we don't have to worry about them anymore. But most of them come back to our communities. And so particularly for people with disabilities, appropriate reentry planning is essential. Reconnecting them to the services that they had or connecting them with new services is essential. During COVID, thanks to some city initiatives, many individuals were able to be released into hotels. However, as it's been mentioned this morning already, mental health services, substance use services, reentry services, case management services in the community were significantly limited as many people were working remotely. And so our patients, the jail population with disability, were re-entering into communities that really lacked the services that were required to address their needs. And so I think just to conclude, I wanted to say that as a society, I don't think that we can properly manage or address health inequalities in people of color with disabilities without paying attention to the system of incarceration, to the criminal legal system, and to individuals who are incarcerated. I think it's important to remember that the social determinants of health and the political determinants of health, as it's been talked about this morning, really overlap with the social determinants of crime. And that the COVID-19 pandemic has exacerbated disparities in this group. It has caused tremendous psychological suffering in incarcerated individuals. And it has also reminded us that jails are part of our communities. And during COVID, this reminder came with the realization that high rates of infection in the jails could result in increased rates of infection in surrounding communities. So healthcare constitutes a public health intervention, but should be considered as just one more service within a continuum of services for this population in our communities. Thank you.
Thank you, Virginia. You covered an incredibly important area that many of us don't know about. And the information about, to me at least, hearing that these are people that are not convicted of anything in a lot of cases, and that they are, in the last year, been held much longer than they would have been. They don't have access to the courts. Their families don't have access to them and vice versa. Just this is a true compounded disparity, and we appreciate your comments on it so far.
Thank you.
Dr. Martinez, love to hear from you. And I want to also remind our panelists, and I talk too fast sometimes. We have people doing interpretation, so
I'm sorry about that.
Not talk like me. Thank you.
Sorry about that.
That's okay. I'm the same way.
Thank you, Marco. Well, good morning, everyone. I'm Octavio Martinez. I'm a middle-aged Hispanic male, clean-shaven with a very short balding haircut. My pronouns are he, him, and his. I'm wearing a light brown blazer, a white shirt with brown stripes, and a rust-colored tie with little blue cars. I'm also wearing black eyeglasses, and I have a headset on. As Marco mentioned, I have the privilege of serving on the Biden-Harris COVID-19 Health Equity Task Force. So I want to take a little bit different perspective than my colleagues have here, but it's all tied together, guys, because we're all one. We're all in this together. This pandemic has affected each and every one of us. But for those of you who may not be completely familiar, the mission of the task force is to mitigate inequities caused or exacerbated by the COVID-19 pandemic. And we are also there to prevent and think about we're also there, to think about how to prevent inequities of the future as well. There are 12 non-federal members, and I'm honored to be one of those. Also, there's a colleague here from the task force, Andy Imparato. Some of you may definitely know him as the Executive Director of Disability Rights California, who is also on the task force with us. So he's one of the 12 as well. We are focusing on 4 areas. And in fact, each of the areas has a subcommittee. The first one is data analytics and research. The second one is health access and quality. The third one is structural drivers and xenophobia. And the fourth is communications and collaborations. So as you can see, these are very, very wide encompassing categories for us to really think in how this pandemic is affecting each and every one of us individually, but also as a community and, of course, as a country. And we're doing this, and I really want to and admire Vice President Harris and, of course, President Biden himself for being so forward with understanding that we need to do this with a health equity lens. Because what does that mean? What that really means is that we are looking at all the different communities that make up the diversity of this amazing country, recognizing individuals with intellectual and developmental disabilities, recognizing those with mental health and substance use issues, recognizing our communities that are home challenged, recognizing the incarcerated, just like Virginia was mentioning, recognizing all our communities of color, including especially even our Native American brothers and sisters, recognizing the LGBTQ community, and so many more, because this is the fabric of America. We are very diverse, and all of us deserve to be included. And so what does it mean to have that health equity lens? It's been mentioned, what is health equity, right? So everyone, and I do mean everyone, should have a fair and just opportunity to be as healthy as possible. That's what we're striving to do. That it would be true health equity, regardless of disability, regardless of race or ethnicity. It means having respect. It means treating all individuals with dignity. This requires, though, removing obstacles, as has already been mentioned, especially by Daniel Dawes and others, the obstacles to health, such as poverty, discrimination, and their consequences, including powerlessness. It means taking on the social and political determinants of health and moving, though, upstream to truly tackle the root causes, such as discrimination, as I just mentioned, and others have, but that structural racism that just permeates so many things that we do and the impacts it's continuing to have. How do we do that? And it's already been mentioned here, and that's why I think this is such a lovely discussion so far. It's about being community-centered. Therein lies not only the strength, but the answers is in community. And so what does that mean to be truly community-centered? It means we need to engage with our community. We need to partner with them, not do for, but do with. Recognize and acknowledge the cumulative impact of the stressful experience in the environments in which we live in, all our different communities. Recognizing, though, the role that privilege and power plays and its impact on us. Creating an environment, though, for public participation. Not blame individuals or groups for their disadvantaged status. Too often, we always want to point the finger at just you, the individual. You're the one that needs to fix this. But you can't, because we need to strengthen the social fabric of those neighborhoods for folks to be able to start to address those issues. We must be inclusive across the entire age spectrum, as well as work across multiple sectors. What we do as human beings is very complex. To think we can only stand up or address one issue at a time isn't working for us. Focus on community determinants through a health equity lens, as I've already mentioned, and measure, and we should track the impact of these social policies, because we know when it comes to data, if we don't gather the data and we don't have the metrics to show what's happening, well, guess what? Many stakeholders will say, oh, a problem doesn't exist. And yet we know that it does. We must build on the strengths and the assets of community members and the communities themselves, and also understand the history of the individual and the history of a community. I guess those whole, the political determinants and the whole concept of, say, redlining, and why does it still have an impact today, where now we are actually more separated than we were in the 1950s. If you take a look at our neighborhoods, the statistics are there. We need to ensure that we all are aware of them. So within that context, leveraging historical successes and failures is key to achieving equity-centered approaches. We must review previous historical efforts that have been done, say for the pandemic, like our vaccine history, and how it's been rolled out for our underserved and marginalized populations in the past. Why? To extract lessons learned that can be applied now, but also for the future. Because unfortunately, folks, this probably will not be the last epidemic pandemic, let alone more epidemics to come. And also, looking at history includes reviewing the body of knowledge that we already have. We have a great body of knowledge that exists as it relates to previous natural and man-made disasters, such as Hurricane Katrina or what's happened, unfortunately, in Flint with the Flint water crisis. There are lessons learned already that we have not taken to scale and implemented. Let's not repeat the past. Let's learn from it and help us to make for a much better and inclusive future for all. So I'll turn it back over to you, Marco. Thank you.
Thanks, Octavio. Great comments. I love the perspective you have, and congratulations again on being in the Biden-Harris Covet Equity Task Force. And you've really helped progress along with the other panelists in this first round, which has been terrific. The comments and the leadership that Daniel Dawes showed us earlier this morning, and I want to progress that a bit if I can. So New York City was at the epicenter of the pandemic a year ago. We all know that. The world knows it. Many things weren't working in the early weeks, and I guess that's expected. You know, who would expect the pandemic to move so quickly? I guess we could have done a little better, for sure, a lot better actually. But we already know that the population we're talking about, this intersectional group, suffered much more significantly than everybody else, as bad as it was. So I want to dive into political determinants a little bit more, and I'm going to ask the panel. Anybody can jump in. What one or two things did you see or experience that have been exacerbated by political or governmental conditions during the pandemic? I'm not going out to blame government per se, but I think there's no question that a national response to a pandemic is essential. And there are political and governmental mechanisms that either impede or accelerate those responses one way or another. So who wants to jump in?
Well, let me just jump in for a minute from the health perspective. And one of the major challenges as a clinician and a provider, but also providing services to folks with disabilities during the whole epidemic is there was so much confusion between the different layers, between the information that was coming out on the city and the state and the national level, and there was no cohesive information. So it left many of us floundering. And again, I followed my edict with do no harm, but there were nights when you just didn't know what to do and you had no place to turn. Let's take, for instance, just in terms of the PPE situation. You know, we knew it was a good idea to have PPEs, protective personal equipment. We know we needed it. We know we needed it, especially in congregate care facilities. But there were times when we had to use the same mask for days at end. We had times when you didn't have any access to information. And I think to speak to the point of what we can do differently or as we go forward, I think it was truly noted that communication and information sharing has to come from the top down. So that's just one of the points I would bring up.
Marco, could I add another point to that? Because Cheryl, you're right on. I totally agree. Consistent messaging, transparency is so important. I think also it's not mutually exclusive that we have to do things on a large scale at the expense of doing things at the community level. I think there definitely must be a top-down. Federal government should be modeling best behavior and best concepts, as Cheryl's pointed out, about communicating. But it's not mutually exclusive that we can also, at the same time, stand up communities and have them help us to roll out these messages, but also what is the best way to address these issues? Because they easily would have been able to tell us, for instance, the intellectual development disabilities community, here's what are the things you need to be wary of. Here's the gaps. Here's our challenges. Keep that in mind as we're rolling things forward. We're there to help. And almost every community that I can think of can also provide that insight. So that's one thing that we've been talking about at the task force as well, Marco, is the fact that we need to be including community from the get-go and not think that we have to always do for them. Let's do with. And together we can actually ensure we're making or addressing something like that pandemic, which was rolling out in real time. That's the other thing that was so challenging.
Let me just add to Just one other point I would add that Brittany Wilson had brought up, and I thought that was key. One of the positivities was the accessibility. Doing telehealth visits, which we couldn't do before, which was greatly, it helped for people with developmental disabilities with some of the challenges. Doing that and having that access to services that we didn't have before has been very helpful. And I hope that's one of the things that we still continue going forward. Thank you.
Yeah, one thing just to jump on to what Octavio was saying a little bit about data, and I don't want to get too much into the weeds on it, we don't have time, but there's no question that the government did not have or did not share the data necessary for this population. And I'm talking now more about IDD, but disabilities generally. There's not a good data set nationally, I don't think, about disability COVID. And in New York State, I think where there were really heroic efforts all around. We use that term a lot, but it's true. I think government tried very hard as well and was successful in certain cases and not in others. But we had to actually develop a data collaborative of organizations in metro area of New York and then move upstate to generate some type of predictive capacity on infection, hospitalizations, and deaths, unfortunately. And we were successful in doing it. And that's what actually fed the terrific work of Scott Landis at Syracuse University. I'm glad we did it, but I feel like it was sort of a public health enterprise that we were engaged in as opposed to government doing that. And hopefully we've learned from that and progressed that capacity going forward. I want to turn to Jennifer for a second because you were on the receiving end, Jennifer, of a lot of guidance from a lot of different places, having to work day to day with people to keep them safe and engaged. So talk about that experience a little bit about having to deal with new information every single day or sometimes multiple times in the day.
Just as Dr. Martinez mentioned, the plan was rolling out and we were in action at the very same time. And just like Dr. White-Scott said, I remember at one point in time, you can contract COVID from touching surface areas. Now we know that's not necessarily the case. So to speak to that, it's disparities, it's the constant updating, it's the constant, no, this works, no, this doesn't work. And we're in a group home setting where we need to know and not hope or maybe try and predict what's correct. Hope is usually a good thing, but we often rely on knowing what was right. So constantly augmenting procedures or protocols, the availability of PPE. Do you wear a mask? Do you wear N95? Is it blue? Is it white? A lot of those things were in question, and we needed the answers. We needed to know the correct thing. We needed to know today that we were doing the correct thing for tomorrow. And often in a group home, that's challenging. People are different, individual. Staffing is of question. And with all these things at the same time, supporting 7 people on the spectrum is difficult. You just hope that you're doing the correct thing.
Thank you. Challenging every single day. Appreciate that.
And can I just speak to Jennifer's too? Jennifer, for you and your staff, people were dealing with amazing mental health issues of their own because they were leaving their families, they were going on the subways, they were in the group homes for days at a time. And I think, as Benjamin mentioned, the mental health aspects and the impact of COVID-19 on frontline essential workers, I think is an understated sort of identity issue that we should also put on the table.
And that includes myself. Every day, I'm still trying to process what happened, me personally, also professionally. Did I do the correct thing there? Was that enough? Was I supportive enough? And I had to make the choice to secure my son, who also lives on the spectrum, and stay at work because I know he was okay. I need to make sure they're okay. And that's where, duty and calling comes in. And I don't know the extent, but I do know that it has strengthened my advocacy, my calling, my position, and hopefully this will be the last pandemic we would ever go through, and I don't have to retain this knowledge and use it again in the future.
Well, let's pivot a little bit. We got about 7.5 minutes left based on my timer here. What is the one thing that each of you would do? And you got about a minute and a half each, to move this forward. We've talked about a lot of things that have happened, and they continue to happen. But we're talking about physical and mental health impact of people with IDD, people with disabilities and of color and COVID. What are the one or two things that you'd like to see done differently, or that you think we need to do going forward? Let's start with Octavio. That's okay.
Thank you, Marco. I'm going to take off something Cheryl said, and we've talked about this, the task force, a great deal, is that we have pivoted. We have stood up certain interventions that for a long time there were barriers to it, especially like telemedicine, telepsychiatry, telehealth. Understanding technology does have a role that really gives access to so many folks. Those dealing with intellectual and developmental disabilities, physical disabilities, but also geographical, our rural communities. So I think the lessons that we have learned, we need to ensure they go forward. And there are many policies that are being put forth, getting to political determinants to ensure at the federal and even at all the states that I know that are doing this, to ensure that we, in fact, utilize these lessons learned. When it comes to the mental health and substance use and IDD, what we can't let or slide back is there's been this silver lining where it was front and center on every television, every radio station, and they're still talking about how these have impacted our entire community, and understanding we truly, as human beings, the importance of a holistic approach, the physical, the mental, and the spiritual. We can continue that. And I'll end with this, Marco. There's another model out there, the collaborative care model for ambulatory settings, which really takes that approach. And standing those up, and let's put together policies that support and make sure that they actually can be maintained going into the future, financially, but also from a workforce standpoint.
Thank you, Virginia.
Well, I think, from, again, going back to my perspective, working with the incarcerated population, obviously, in a pandemic like this, it's just inevitable that the infection rate will be high in people who cannot physically distance. And so really looking into the future, the only solution is to not have that many people incarcerated. And I would say that during the COVID pandemic, probably a combination of bail reform and a lot of people who were released because of COVID, the population did go down, and it definitely made it easier for us to be able to manage the behavioral health and medical needs of the incarcerated population. It made it easier for at least some areas to be able to social distance. And I think it prevented a much worse tragedy in the jail system. But that has changed, as you all know, right, recently. So the numbers of people who are incarcerated have gone up to pretty much the same numbers that were before the COVID pandemic, and continue to go up, although now a little bit slower. And so I think that the incarceration continues to affect the same groups, right? Continues to affect minorities and people with disabilities and people who have experienced trauma, neglect, abuse. And so I believe that we need, actually, New York City has a lot of alternative to incarceration, special jurisdiction courts, but it's not enough with that. We have the agencies to connect with, but we need the community services to be able to divert these people into. And those community services need to, reduce the stigma of working with this population, tolerate a level of behavioral agitation and violence, and treat it as a health issue, and not dismiss these individuals from their, residential treatment programs so quickly. We really need to be able to treat these individuals in the community if we really want to decrease the number of people who are incarcerated. And of course, address structural racism and discrimination at all of the different points of decision-making within the criminal legal system.
Thanks very much. We've got 3 minutes left. Go to Jennifer. one thing you would like to see done differently, or we could do differently?
One thing that speaks to me that I would like to see differently is more connection between the DSPs or the professionals that work with the people supported and the healthcare practitioners. 3 instances in my case and 2 others through other people, we weren't, in all honesty, quite listened to. And I think it's because the person supported was nonverbal and they couldn't express what they felt or was going through. And now that person is relying upon me, a person, I'm the person who sees them every day, works with them often, and I know that they are not well, even though they can't say it. And I felt a disconnect between myself and the healthcare provider. I felt a disconnect between empathy and also just understanding that I know this person and I can express for them that this isn't typical behavior, or they are struggling right now and they should be seen. And maybe they aren't unconscious, but they are sick and should be seen now and versus later when they're sick enough.
It's a terrific point, and it fits into what Octavio said about the collaborative care model. So thank you for that. Cheryl.
Okay, real quick, and I'll take a breath. Credible data with diverse representation. We need to deal with education and training of health professionals, as Jennifer just mentioned. We've got to deal with true cultural competence. Thank you, Professor Good. We have to deal with crisis standards of care guidelines, as Brittany Wilson had brought up earlier. Who got the ventilators and why? Vaccine distribution, there were still differences in the allocation. Shout out for New York being put people in the 1A priority case, but there were still differences. And I would have to say that last point is, let's not just make this a conversation and a video and nothing happen afterwards. So Octavio, we're giving you that charge for the Health Equity Task Force, but also for one another to really make a difference in the lives of people. And then Sylvia would have really been heard. Thank you.
I'd like to thank this terrific panel for your insights today. I'm seeing stuff in the chat, which is really interesting. And the attendees here are also asking, supposed they appreciate the conversation about what happened. They're looking for what needs to happen. And I think you've helped inform that. I know that the panels that are coming up will also do the same. So thank you again for all that you do, for your conversation today. It's been a pleasure to be with you in the panel.
Thank you.
Thank you. Thank you all.
Hello, everyone. Marco, thank you so much for moderating such an important and powerful panel. And thank you, Jennifer, Dr. White-Scott, Dr. Barber, and Dr. Martinez. Thank you for sharing your valuable but also painful experiences of challenge and struggle over the last year. It's important that we talk about it. It's important that we reflect on what we can do better and make this more than a conversation.